Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Hi, everybody. Today, we're so fortunate to have the amazing Dr. Mark Pimentel, who is not only a leading gastroenterologist, but he's also executive director of the MASS program at Cedars-Sinai in Los Angeles, California. He's also the author of a book called The Microbiome Connection, Your Guide to IBS, SIBO, and Low-Fermentation Eating. Now, I'm very interested in this personally, so I can't wait to get into our conversation today. But a huge welcome to Dr. Pimentel. Thank you so much for joining us today.
Oh, thank you. It's great to be here. I'm looking forward to the conversation. And all the team behind you that you see sort of moving around, they're doing something in the kitchen, I think.
Taking away all the food. It's time to stop eating, everybody. They're hiding it all.
But the lab is in the back. And
that's so cool. That's a really nice. At first, I thought you were at Starbucks or something.
No,
it looks very.
Through the second set of glass back
very
there,
cool.
You can see the laboratory, and that's where all the science is done.
Oh, no, this is fascinating. I mean, you've been in this space. I remember when I first started as a blog, when I was at when I was at Revolution Health, and I got one of your first books, and I was like, and I talked to you way back when, and you always do fascinating things. So many patients that write us and have questions involving SIBO, which is small intestinal bacterial overgrowth. And even myself included, don't know much about it. Always curious to know more, and also with a connection with other digestive conditions like IBS and how it overall relates to our microbiome. So I thought today we'd frame the conversation in 5 things that patients should know about SIBO. How does that sound?
That sounds perfect.
Okay. So what's the first thing that patients should know about SIBO?
Small intestinal bacterial overgrowth, or SIBO, is changing, of course, so as we start to understand the microbiome. But what I want people to know is it is not an infection. It is a colonization of the wrong kind of bacteria in your small intestine at a very high number. And so anything you eat, people say, well, I can't figure out what to eat. Well, they're sharing on every dinner plate you have, but there are ways to give them less from the dinner plate. And some of the stuff, we'll be talking about during this conversation. But basically, bacterial overgrowth, or SIBO, is an excessive number of bacteria in your small intestine where they don't belong.
Interesting. Now, for number 2, what is the second thing that patients should know in terms of what are some of the symptoms of SIBO?
So it's really important to understand that the gastrointestinal tract can only tell you certain things. You can have pain, you can have bloating, you can have diarrhea, constipation, nausea, and vomiting. That's it. But we got a book this thick of GI disorders, and those 5 symptoms are in many of those GI disorders. So it's a little tricky, but specifically SIBO is this. You do have discomfort, you do have diarrhea, you can have constipation if you have EMO, which is a form of SIBO, but it's a different name that we now give it, and I'm sure we'll get into that. But bloating is a big part of it. So you wake up in the morning, your abdomen or your tummy is flat-ish, and as the day goes on, and as you eat more food, your stomach starts to accumulate all this gas, and you get bloated and distended because the bacteria are fermenting because they're living in the small bowel. They're not getting your leftovers in the colon anymore. They're getting your fresh food. They're sharing in every meal that you have, all the good stuff.
And the small intestine plays a major role in our digestive system, correct?
Oh, absolutely. The small intestine is where everything happens. And one of the things that sort of perplexes me, and even among some of our gastroenterology colleagues, is you can fill the colon with gas. The colon is 3 feet long. If you fill the colon with gas, it doesn't take up much room. Half of the colon is behind where the kidneys are. If you fill 15 feet of small bowel with gas, boy, you feel it. And so the small bowel, when you get bacterial overgrowth and you start producing or fermenting gas in there, I kind of put it like this. The small intestine, if you were to spread it out, it's the area of a tennis court. Imagine spreading a thin layer of peanut butter, being bacteria, on a tennis court and then putting food on top of that, how much gas that can produce. So it's miserable for these patients.
So the number one is bloating, which we know is also, like you said, a symptom of many other digestive health issues, such as IBS. So how do we know, as our number three, what we need to know about small intestinal bacterial overgrowth? How do we know if it's IBS or SIBO?
Well, I sort of look at it this way. So if you look at the most recent meta-analyses, this was done by a Dr. Shaw from Australia, where you take the 25 studies that have looked at the prevalence of SIBO in IBS, and it's way higher. We think that 60% of IBS-D patients, the diagnosis is actually SIBO. But if you go back to H. pylori and peptic ulcer disease, and I use this analogy a lot, you have an ulcer, and about 70, 60, 80, I don't know, it depends on the study, percent of ulcers are caused by H. pylori. But we didn't change the name. We didn't say it's H. pylori disease or whatever. We just said, okay, people, if we're mature, it's peptic ulcers caused by H. pylori. So the question is, it's IBS caused by SIBO is sort of how we're seeing it today. Now, maybe in the future, we'll just outright leave it as SIBO and get rid of the IBS part of it. Because remember, irritable bowel syndrome is abdominal discomfort or pain, diarrhea or constipation, and then minor things are bloating and all that. Minor meaning they're not part of the core criteria. Well, everybody with a GI disorder has abdominal pain or discomfort or diarrhea. So the Rome criteria don't help us much. And the other thing is, if you meet the Rome criteria and you get an endoscopy and everything's negative, they put all of what's left in this basket and call it irritable bowel syndrome. And so we're not expecting SIBO to be the cause of all of IBS, because IBS is probably a mixed bag of a whole bunch of different things because it's all the leftovers. But it's pretty good to know that 60% of IBS is caused by one thing, SIBO, and that's how we see it.
Well, I think this is great news for patients, right? Because patients, one of their biggest complaints and things that drive them nuts is when the doctors always lump everything. Oh, we don't know what it is, so it's IBS. And they just lump it in there, and it drives patients bananas because they don't really find a solution. We're going to talk about, some of the ways we can maybe address the small intestinal bacterial overgrowth, but it's not really, some of the treatment options aren't really helping patients, right? They're not really helping patients in the right way. And it's like, oh, well, maybe, there's something else. And that's why I'm really excited that we're having this conversation, because it's something that patients, I think, have been asking for and they want to know more about. Right. So you have IBS patients, there may be some indication that it could be SIBO. How is it diagnosed? How do we find out if we have this?
Well, I want to go back to your previous point, because I think it's extremely important. Probably some of your viewers have inflammatory bowel disease, right? Crohn's, ulcerative colitis. Yeah. And would you, even in your wildest imagination, imagine your doctor prescribing you Imodium for your Crohn's disease?
No.
Or prescribing you an anti-nauseant or a tricyclic antidepressant for your Crohn's disease? They would say, are you kidding me? We have to treat the cause. Why would IBS be any different? Why would we give IBS Imodium or tricyclics or some, psychiatric medication? Treat the cause. And so really, if I reflect back on my career, 26 years at Cedars, from the beginning, I like the idea that you find a cause that's treatable, treat the cause, cut the root out to make the patient better. Imodium will work for Crohn's disease. It'll stop the diarrhea, but the ulcers aren't gone. The bleeding isn't, so it's not treating the illness. It's just treating the symptom. You have a wound on your skin, you put a Band-Aid on it so nobody sees it, but you don't fix the wound. And so that's how I see it. But in terms of answering your question, which is the diagnosis of small intestinal bacterial overgrowth, crazy amount of new stuff. I think you were at DDW. I don't know if I caught you in the hallways, but crazy amount of new stuff in terms of the microbiome and SIBO. One of the things that we showed was that, and to a surprise for us too, we knew SIBO was there. We knew it by breath testing. We knew it by culture, but we never went down to the shotgun sequencing level, which is, we know the species and the strain of bacteria that are causing SIBO. And the shocking thing is, and I said at the beginning of this is not an infection. but boy, it sure looks like one, because when we look at the deep sequencing of the small bowel of a SIBO patient, half of every bacteria that's in that small bowel are two bugs, Klebsiella pneumonia and pneumoniae and E. coli. So
oh wow,
500 bacteria now boiled down to two bugs are taking over half of everything. And we were shocked. We thought it'd be a bunch of different sort of coliform bacteria, but it's two characters that ruin the whole city. And so I think that's amazing. And the things that are predicted by those bacteria are hydrogen will be elevated. Not only, and this is really important going back to the symptoms, not only are the bugs that are elevated produce hydrogen, but they're jacked up to fire through carbohydrates. So what we see is, so all bugs ferment, but the characters that are involved in SIBO are super fermenters. So if you want to produce gas at 100 miles an hour instead of 2 miles an hour, these are the guys. And so that's why people, they say, oh, I just ate and I'm already gassy. These fermenters are super fermenters, and they produce hydrogen. And we proved at DDW that they also produce hydrogen sulfide. We've known about hydrogen sulfide for a couple of years, more than a couple of years, but the sequencing shows that hydrogen sulfide is jacked up as well. And so hydrogen sulfide causes diarrhea. Hydrogen causes a lot of the bloating. And, so we principally do a 3-gas breath test now, which measures methane, hydrogen, and hydrogen sulfide, which is on the market. And we helped develop that test.
That's incredible. I mean, that's incredible. And it's pretty groundbreaking to identify those two bugs that are like the cause of all these problems consistently. That's crazy. So what is your recommendation for patients who want to get that test, who want to see if they have small intestinal bacterial overgrowth?
Well, I mean, you have to be your own advocate, and I think that's the main thing. So the test, and I've been involved with the company because we helped develop the test, is called TrioSmart. That's the one we use, which is a 3-gas breath test. You can request the doctor to order. It's super simple. If they do their own tests, you could get hydrogen and methane just with some of the hospitals that do that testing. Right. But if you're diarrhea, I mean, the hydrogen sulfide is critically important because the treatment for the 3 gases is different. Hydrogen is rifaximin, was what we do, and we're going to get into that. And hydrogen sulfide is different. So, you have to know what you have in terms of your gas profile in order to understand the microbiome, in order to know what to treat and how to treat.
Well, this is really fascinating because it's very much leaning towards targeted treatment, right? You just said if it's and this is really exciting, and that's where we're going, I think, in healthcare, especially when it comes to the microbiome, identifying some of those bugs and bacteria and what would be the best treatment for that. So this is really exciting, actually.
No, it's
fascinating.
Yeah, the last 2 years things have changed a lot, and now we know the cast of characters by name. And so by knowing them by name, it will lead to better treatments and newer treatments. And I know I say this sometimes on podcasts and it frustrates patients, but what we present at DDW is 2 years behind what we actually know, because we are already 2 years ahead of that data. So imagine what that looks like. Right. And we can't talk about it yet, but we have therapies that we're working on based on all that microbiome data that I just mentioned that we presented and publicly disclosed, because now we know the cast of characters, we now know the drugs to treat, and we're working through that, and hopefully there'll be new FDA therapies in the near future.
Well, I think this is exciting for all patients, and especially those with IBS who often get lumped into a category and with very limited types of treatments. I mean, there's diet, there's certain medications, and obviously behavioral stuff, but a lot of patients don't find relief from any of those still, right? Because we're not getting to, like you just said, the underlying cause of the problem and not just the symptoms. So this is exciting. So another question I'm sure patients are going to ask, is it covered by insurance? Can patients take it on their own and then show the results to the doctor? What do they need to know about that?
Well, there are ways to take it on your own. They have third-party physicians that clear things and make sure that you're not just doing this for fun. Right. But everything goes through the insurance first, so you're not paying up front and all of that. So generally, it's Remember, breath testing has been around for 25 years. So the CPT codes, the billing is well streamlined with insurance companies. So it's not like some new extreme expensive drug. This is breath testing. It's pretty simple, straightforward, and not that expensive.
And for the providers who may be listening, what would you say to them in terms of if they have patients and requesting this test for them? Like, what would you say to them as sort of encouraging them, to take a look at this test and recommend it to their patients?
The microbiome is really complicated. And if you read those papers, they're really hard to read and harder to write for us to make it as clear as possible for a regular doctor who's a primary care somewhere to read it and understand it and know what to do with it. We do host a gut microbiome course for clinicians. It's coming up June 3rd and 4th because we want to, take that language, translate it into English or into doctor speak or MD speak so that the doctors know how to use it in their practice. And so we've been trying to do that for a number of years to educate physicians. But you gotta know this stuff. And if you don't know this stuff, then you can't help your patients, and all you're doing is the same old for 20 years. And so I think physicians need to come back to the table, get re-educated. But it's easy to get the test. It's so easy. It delivers to your house.
What are sort of, now that we know some things that may be causing it or risk factors that could contribute to an overgrowth of this bacteria? Is it things that we're eating? Is it processed food? I saw some things that you talked about with like artificial sweeteners, which was interesting because so many people chug a lug those drinks with all these artificial sweeteners in them. What are our risk factors, and what are we doing that's going to perpetuate all this stuff in our gut, the bad stuff?
Well, so we do know that bacterial overgrowth occurs for a number of specific reasons. So for example, if your bowel's obstructed, things aren't flowing. It's like your bathroom drain or your kitchen sink isn't draining, and that stuff starts to smell because bacteria start to grow on it. Same thing in the small bowel. But that's not common. What's most common is that it's a motility problem of the small intestine that's caused by food poisoning. So we think food poisoning is the ultimate cause of that 60% of IBS, and it does so by damaging the nerves of the gut, leading to the gut being slow, specifically the small bowel, leading to the buildup of bacteria. And then these two characters love the slowness, and they win. And they win the day. So that's the stream of consciousness of how it happens. But now that you have it, speaking about diet, any carbohydrates you eat have a potential. I mean, you can leave oil on the counter at home, right? You don't refrigerate your olive oil because bacteria are not going to grow in the olive oil. Change that by putting a teaspoon or a tablespoon of sugar in that olive oil. That olive oil will go bad in 24 to 48 hours. So the bacteria don't care about oil. Of course, probably need a little bit of it, but that's not their primary ingredient. They have one primary ingredient, it's sugar. And if you eat sugar and you're grabbing it, they get less. If you eat sugar that you can't absorb because it's 0 calories to you, they get all of it. And so, if you eat sucralose or stevia or sorbitol or, you name the alls, maltitol, all these things that are in sugar-free this, sugar-free that, you're giving all the sugar to them. And if you have overgrowth, you can imagine that just creates, havoc and bloating and gas and distension. I had a patient who came to me. He knew for years not to eat non-digestible sugars and these artificial sweeteners. And then he says, "Oh, I'm bloated out of my mind." And I said, "Well, what are you doing differently?" I said, "Walk me through your day." And what happened was he stops at a smoothie place in the morning to get his morning kick. And they piled sucralose into that smoothie, and he didn't know. And this was what was causing his bloating. Anyway.
So wait, whoa. So now all of us who think that we're doing good by adding stevia or something to our coffee, or, there's, I think even at Whole Foods, you can get the colas that have stevia in them. We think, okay, this is healthy.
Yeah.
We're actually not. This is so bad. Not just the aspartame things that we know is bad, Diet Coke and all that stuff.
Well,
other stuff.
I'm going to shock you a little bit. Aspartame is a protein. So
Really?
it will not hurt your SIBO. Aspartame maybe does other things,
Yeah.
but aspartame is the one sweetener that's totally okay with SIBO because it's not a sugar. It's two amino acids stuck together.
Interesting.
So, but what we showed at DDW, which you were alluding to, the Helio article covering our abstract, is that interestingly, that protein, aspartame, does very little to the microbiome because it's just a protein.
Oh.
But all the others, I think there's 76 different changes in the microbiome, and a lot of them not good. So because they're basically feeding the garden, bad stuff. So it's sort of like you have a bunch of children in the yard and you give them all different kinds of candy, and then you ask them to behave. And of course, we know what happens. Yeah.
I'm speechless with that aspartame comment.
Right?
And not that I avoid it because I'm afraid I'm going to have like some other problems, but oh my God, it's just shocking.
Lots of new things.
Yes, like there's so much to know. But now once we know we have SIBO, small intestinal bacterial overgrowth, what can we do to combat it and find some relief? I'm really interested in the book you wrote, and you talk about low fermentation eating. Does that have a relationship here? For someone like me, I see fermented food and I think, oh, this is healthy for my gut. I'm going to eat some kimchi and I'm going to, down some kombucha, and this is all great. Meanwhile, if I'm having a problem with small intestinal overgrowth potentially, or even IBS, am I doing more harm than good?
The answer is yes. But let me sort of put it in a different way. So I told you I've been doing this for 26 years, and I'm not trying to just keep saying how old I am.
No, you're amazing.
But I'm getting old. But my point is, when we started this story, the goal was find the cause, treat the cause. I said that already. The other thing is, IBS patients are miserable. SIBO patients are miserable. And they go to a restaurant with their friends. They don't want to go. They don't want to be there and bloated. They don't want to get up from the table and go to the bathroom and disappear for half an hour with diarrhea when they have friends around or they're on a date or whatever. It's miserable, right? So why would I add misery to them by giving them a diet where they go and they have to ask the waiter 10, 20 questions, whereas everybody else orders the burger on the menu, right? So I said, we have to have a diet that deals with the microbiome, that doesn't cause nutritional deficiencies, and that they could find at least one thing on any menu in this country, so that in the case where they just want to order and get it over with and not look like the sore thumb at the table, they could. And so the low fermentation diet tries to check those boxes. It's less fermentables, but if you ate nothing, you wouldn't have gas, right? The low FODMAP diet is really restrictive, which means it works, but you can't stay on it because it's not nutritionally balanced.
Right.
So we're a softer version, and in fact, we developed it in 2002 before the FODMAP was developed.
Oh, wow.
Yeah, and we've been giving it to our patients since then. Some modifications since, because different sweeteners have changed. But we want people to be able to live their life and not be socially isolated and have all those problems. So the diet's meant to be, you can use it chronically because you don't get any deficiencies. You're just eating sugar, but sugar, not the sugars that are hard to absorb and digest. And so we're very specific with what things you can eat that are carbohydrates and what things you cannot.
So just as an example, like what are some of the highlights of the things that you can eat on a low fermentation regimen?
Lowish fiber, because fiber is just fermentable. We recommend that you not eat any of the non-absorbed carbohydrates except for aspartame if you really want a 0-calorie sweetener. If you're going to make a cookie, make it with sugar. Don't eat 20 cookies. You can have 1 cookie. And then we do low lactose or no lactose as another aspect of it. And then the final thing is, we know that the motility and specifically the cleaning waves of the gut are not working, and that's why you're getting the SIBO. And the cleaning waves only occur on an empty stomach. So if you're eating all day little bits and noshing, like because the break room has bagels in it, that's not going to work because you'll never have a cleaning wave. So the other part of it is you eat what we suggest and you only eat your meals and nothing in between, so that you give your body a chance to rest. Because the body, when we were evolving as humans, you killed the buffalo, you ate the buffalo. What did you do with the buffalo? You don't have a refrigerator, so you eat what you can, and then you don't eat for 3 or 4 days until the next kill, right?
Right.
So we were designed with those cleaning waves to occur when we're not eating. Therefore, we were designed not to eat all the time. We need those cleaning waves to keep the bacteria down, to keep the small bowel clean, like a dishwasher washing its dishes. And so if you're eating all day, you're not cleaning. And that makes, more problems. So it's lifestyle combined with specific instructions on what not to eat, combined with how to eat to maximize cleaning waves.
So we're not talking about fasting and for long periods of time. Mm-hmm. We're just having like more of a regimented, and then not like my grandparents. I remember they would just have their meals. They ate nothing. They would finish dinner, brush their teeth, and never eat another thing for the rest of the night. I mean, that's what they did. They ate clean and they never had any problems. You know
what? First thing I say to my patients is, your mother had it right. Your grandmother had it right. They knew what was going on. They didn't understand why they knew, but they knew. And so that's it. You once you're done eating, you're done eating. Don't go back to the fridge over and over and over again in the evening.
No, this is great. Yeah, and the book sounds amazing. Are there any other highlights of the book? And we're going to put information where patients can check out the book. Can they do this on their own, or do they need to have a dietitian? Is it something that they can follow? Like the low FODMAP diet, for instance, is pretty challenging. So you kind of have to work with someone who, can help so you don't have any deficiencies. You
read the book, you'll be able to do the diet because it's not that restrictive, as I said. So it should be pretty straightforward. The book gives that explanation.
In closing, what is the last thing and the final thing that you'd like patients and providers who are listening? We do have providers who listen in, should know about SIBO, and what is your recommendations going forward?
Well, so I think SIBO is a thing that needs to be treated. SIBO needs to be diagnosed correctly so you know what treatment to give. So if you have hydrogen, we give rifaximin. If you have hydrogen sulfide, we suggest rifaximin with bismuth. If you have methane, we suggest rifaximin with neomycin or metronidazole. If you follow that, which is based on the evidence that's published in the literature, you're going to have a greater success with your patient. But if you don't know which gas, you're just shooting blanks in the dark. I have many patients who come in and says, doctor gave me rifaximin, it didn't work. Well, you have methane. Rifaximin alone doesn't work. And then we give the proper treatment and all of a sudden they're getting better. So know what you're doing, treat according to what you know, and then get them better. And then, think about the patient's lifestyle. Think about the things that aren't going to hurt them because, you want to try this, that, and the other thing. And stop treating this with Band-Aids. Let's treat the cause.
This has been so great. I hope we have you on again as we learn more and more about this. This is a very fascinating topic. Thank you so much, Dr. Pimentel, for joining us today, and good luck with all of your research and your programs that you have underway looking at the microbiome. It's really exciting.
Well, thank you. I really appreciate the time on this podcast, and I hope your viewers get something out of this.
Yeah, no, I do too. I'm sure they will. This is great, and appreciate your time. I know you're very busy. Thank you so much.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.